Bismillahirrahmanirrahim. Our lecture today is about abnormalities of amniotic fluid. We will talk about three items: meconium staining in the liquor, and according to the amount of liquor we will discuss oligohydramnios and polyhydramnios. First of all, meconium staining. What is the incidence of meconium staining of liquor? Is about 7 to 22% of all pregnancy. It is uncommon before 38 week, but it is very common in post-date and especially after 40 week. This image show staining of the amniotic membrane with thick greenish brown meconium of the baby. What is meant by meconium? What is meant by it is the earliest stool of an infant in the early neonate and intrauterine also. It is a thick material formed of GIT secretion, intestinal epithelial cells, lingual hair, mucus, amniotic fluid, and bile and water, and may be excreted from the anus into the amniotic fluid and be aspirated by the fetus. The meconium have certain colors: yellow, greenish black, or very sticky. Sometimes it can become terrier-like, the adult, okay? The adult ones may be classified also into light or thin meconium and heavy meconium or thick meconium. الميكونيوم passage associated with what? Increased of fetal acidemia. It will increase the cesarean section rate and also perinatal mortality and morbidity of this pregnancy. Meconium. Meconium aspiration complicate about 12% of the birth, and 5% of fetus will aspirate this meconium. It is very toxic to the lung. It may lead to meconium aspiration syndrome, which lead to pneumonitis or pneumonia, and later baby fail to survive and will die with ERDS. Evidence of that, also we have an evidence that it inactivates surfactant, so it will lead to collapse of these alveoli and a lung collapse or atelectasis will lead to ERDS and neonatal death. What is the management? المانجمنت يبقى no difference in blood pH of a neonate with or without meconium if the heart rate is normal. If the heart rate become abnormal, we have deceleration, we have acceleration, we have these two pattern acceleration deceleration as regard a change في البasal fetal heart rate, and also we have beat to beat variability, and later on we have bradycardia and tachycardia as these all are changes in fetal heart rate can be recorded by a CTG. Okay, if there is evidence of acidosis is increased with abnormality in fetal heart rate. So urgent cesarean section must be undergone. Grading of meconium and the management. We have 3 grades. Okay, for first grade we have biophysical profile is well and good, enough amniotic fluid plus light meconium, so stop oxytocin and follow up with the case. Grade 2, enough amniotic fluid with thick meconium. Do EPG for the baby or pH sampling for the blood gases, okay, and to evaluate again. If become oligohydramnios and thick meconium, urgent delivery with cesarean section. Meconium and the newborn. 35% will from a neonate who aspirate meconium were complicated with pneumothorax, persistent pulmonary hypertension related to meconium, and 4% will die. Treatment is standard by suctioning of this material from the mouth and the nose of the baby when the head and the neck are delivered, before shoulder is delivered. What is the disorder of amniotic fluid volume? We have 2 disorders we will talk about. First is oligohydramnios, second is polyhydramnios. Normally we have amniotic fluid volume increased to about 1 liter or more at 36 week of gestation. In the post-term pregnancy, it will decrease by and reach to only 100 to 200 milli. A normal value of amniotic fluid vary according to duration. We have at 12 week of gestational age, we have about 50 milli only. At 24 week of gestation, we have 500, and at 36 week of gestation, we have 1 liter, and decreases therefore till reach to nil at 44 week of gestation. At term, a normal range in a single baby is about from 500 to 1500 milli. Polyhydramnios. Definition of polyhydramnios is amniotic fluid volume is more than 2 liter, okay, or deepest, or diameter of the deepest or the large pocket of amniotic fluid is more than 8 centimeter, okay, or amniotic fluid indices is more than the 50 the 90 percentile for LH. These three definitions equal to each other all mean polyhydramnios. The incidence of polyhydramnios is about 1 to 4% of pregnancy. What is the types of polyhydramnios? Chronic and acute. Chronic, the gradual accumulation of the fluid slowly, we usually in the third trimester after 30 weeks of gestation, we 10 times more, it is very common, more than the acute polyhydramnios, and less dangerous than الأكيوت polyhydramnios. أما الأكيوت فبيبقى excessive rapid accumulation, quickly accumulation of الامنيوتيك fluid, وusually between في الميد second trimester and lead to termination of this pregnancy or miscarriage, early miscarriage, usually with twin, especially monoamniotic twin. With sonography, we have mild and moderate and severe one. The mild in 80%, moderate in 15%, and the severe only in 5%, thanks to God. Mild, it means that the deepest pocket is about from 8 to 11 centimeter. Moderate, deepest pocket of amniotic fluid is more than 12 centimeter to 15 centimeter, and then the severe is more than 16 centimeter. الطيب الcauses all any morbidity related to pregnancy have a fetal, maternal, and current placental cause. As regard the fetal causes of polyhydramnios, we have multiple pregnancy, hydropsis fetalis, and fetal anomaly, the three common causes of polyhydramnios. What is meant by fetal anomalies? We have a very common one, neural tube defect, anencephaly, and spina bifida. These are the commonest cause of polyhydramnios. Because there is increased transudation of CSF and escape to amniotic fluid, also excessive urination due to stimulation of CNS centers and impaired vasopressin اللي هو EDH hormone secretion. Duodenal atresia, so the baby cannot swallow this fluid, the fluid accumulate with throughoesophageal fistula. Maternal causes. Maternal causes, we have diabetes, preeclampsia, heart or renal failure. Okay, diabetes due to maternal hyperglycemia lead to fetal hyperglycemia, so osmotic diuresis. Also في preeclampsia due to placental edema. Heart or renal failure, the baby mimic his mother. Idiopathic case is about 30 to 50%. What is the symptoms? Dyspnea, edema, oliguria, dyspepsia, upper and lower pressure symptoms. This image of acute polyhydramnios in a very thin, cachectic female, pregnant female. How to diagnose? We have clinical diagnosis and the ultrasonographic diagnosis. Clinical diagnosis, uterine enlargement, become larger than a period of amenorrhea, and difficulty to palpate fluid part. There is a thrill in the fluid thrill, positive fluid thrill, and there is a difficulty to hear fetal heart rate. By sonography. By sonography, we classify according to degree, as we mentioned before in the previous two slides. That to mild, moderate, to severe, and its percentage in general. With sonography, there is confirmation for the diagnosis if the vertical pocket more than الأبر normal اللي هو 8 centimeter. We have 8 centimeter to 11 and from 12 to 15 and from more than 16. This 3 degrees. Okay, or another definition, amniotic fluid index is more than 24 or 25 centimeter. Okay, أو إن amniotic fluid index is more than 80s 90s percentile for gestational age. Detect the degree, mild or moderate or severe. Detect also the cause by the 4D ultrasound to evaluate a congenital anomaly. This image of abdominal ultrasound showing that the pocket depth is increased. It is a polyhydramnios. What is the differential diagnosis? Twins, ovarian cyst, full bladder, hydatiform mole ascites, and all can be differentiated from each other by ultrasound. Complication: Brom, all have a P. Brom, prolapse of umbilical cord, placental abruption, postpartum hemorrhage, and also في اللي هو labor dysfunction, uterine dysfunction or labor dysfunction. Pregnancy outcome. In severe cases, we have a very high rate of mortality rate. mortality المانجمنت we have في الماينور degree if البولي هيدرامنوس ده just follow up of the cases و require treatment والدليفري بيبقى at 37 week. المودريت degree can usually managed until labor also start. If there is any complication, we will have urgent cesarean. The severe degree, which have upper and lower pressure symptoms, hospitalization, and they take our the further investigation, then management. Treatment. The treatment, we have amniocentesis, we have conservative one, is in form of amniocentesis and the endomethacin, and we have labor decision. Okay, amniocentesis, we will aspirate by about half liter per hour and not more than 2 liter per day. Endomethacin is one of the drugs, one of non-steroidal anti-inflammatory drugs that decrease the lung liquid production, decrease the urine production by the fetus, and also increase the fetal movement across the fluid movement across the fetal membrane, so will decrease the degree of polyhydramnios. طيب الدوز of الاندوميثاسين is 100 milligram as a loading dose, then 25 milligram oral tablet. Okay, every 6 hours and 4 times per day. Maximum is 3 days. Okay, and cannot be given after 31 week of pregnancy, of gestation age or of pregnancy. Why? Endomethacin will lead to a premature closure of الارتيريا ductus arteriosus, which will lead to pulmonary hypertension in the fetus and or in the neonate, and congestive heart failure and the neonatal death later on. Second part of our lecture is about oligohydramnios. A definition: marked deficiency of amniotic fluid above the normal limits, where the incidence is 0.5 to 5% of all pregnancy. In general, oligohydramnios is less common and more is worse in prognosis than polyhydramnios. الcauses: we have fetal one, maternal one, idiopathic one, and drug one, and placental one. في البلاسنتال usually placental abruption will lead to increase in intrauterine pressure, brom, then oligo. Okay, الماتernal very common with all causes which lead to uteroplacental insufficiency, hypertension with pregnancy, and diabetes if reached to class D اللي هي with vasculopathy. الفيتال part fetal chromosomal anomalies, congenital anomalies, intrauterine fetal death, IGR, post term, brom, twin to twin transfusion. We have one with polyhydramnios and one with donor هيبقى with oligohydramnios. طيب الدراج او الايديوباثيك الايتروجينيك causes caused by doctors. If we give to the patient prostaglandin synthase inhibitor like indomethacin after 31 week of gestation, especially angiotensin convertase enzyme inhibitor as a drug of hypertension during the pregnancy. Clinical picture, اليوترس is small, molded over the baby. Fetal heart sound can be easily heard. Fetal movement decreased and even immobile. By ultrasound, vertical pocket is less than lower normal اللي هو 2 centimeters. usually تبقى less than 1 centimeters. Amniotic fluid index is less than 5 centimeters. What is the complication? Complication during the pregnancy, we have fetal hypoxia, persistent position of the fetus, limb deformity, the talipus or ankylosis of a joint, with pulmonary hypoplasia. This is image. This is image of the congenital anomaly which caused by the oligohydramnios. This image of ultrasound, okay, by and the small pockets lesser than 2 centimeters, and also the lower one اللي هي B الimage B ده deformity في الليمب. During labor increase the variable deceleration وبيبقى فيه increase في cesarean section rate. What is the treatment? We have amnioinfusion, infusion of a saline into the uterine cavity throughout the abdominal wall by a spinal needle to increase the amniotic fluid volume and to make dilution of the meconium. Prognosis is poor. If it is early onset, it will be poor. Thank you.